Our focus in this presentation is on quality of care as it relates to experience of care during facility-based childbirth. I will briefly describe what respectful maternity care entails and why we should care, and present findings on the women-reported experience of care during facility-based childbirth from exit interviews with women, qualitative interviews with women at home, household surveys, and from the Scratchers experiment conducted during household follow-ups with women. Finally, we will reflect on implication of findings from this work. Respectful maternity care focuses on the interpersonal aspect of maternity care, emphasizes the fundamental right of mother, newborn, and families, including the protection of women's right to choose and have preferences. Respectful maternity care recognizes that all childbearing women need and deserve respectful care and protection from disrespect and abuse during facility-based childbirth. Having well-equipped health facilities or highly trained care providers is of limited value if a woman will not seek services in that health facility or from that provider because she or her sister or a neighbor have received abusive or disrespectful care. Women may choose to stay at home without care or treatment rather than subject themselves to abusive disrespect. One of the causes consistently mentioned for the suboptimal institutional delivery coverage in Gombe State and Nigeria is the negative experience from services received. Considering every pregnant woman is at risk of obstetric complication, access to timely and appropriate obstetric care remains imperative to improve maternal and newborn health outcomes. Therefore, every health system should strive to improve the quality of care provided to women during facility-based childbirth, both in terms of process quality and experience of care. The main aim of this work is to understand quality of care as it relates to experience of care during facility-based childbirth. To assess reported experience of maternity care, we conducted exit interviews in 10 primary health care facilities with the highest number of births with recently delivered women upon discharge after delivery. We used structured questionnaire covering content of care provided to the mother and the newborn and the experience of care during facility-based childbirth. We conducted qualitative in-depth interviews and focus groups in 2 communities, Kaltungo local government an LGA with high facility delivery, and Kwame local government, an area with low facility delivery. In the in-depth interviews, we focus on motivation of women for facility-based childbirth and their perception of quality of care received, including respectful maternity care. While in the focus group discussion, we focus on gaining further insight into women's shared understanding of respectful maternity care during facility childbirth and gain group consensus around themes identified in the in-depth interviews. We also collected data on experience of care from women during IDS household surveys. Finally, we conducted the Scratchers experiment during household follow-up of a random sample of 450 women. The Scratchers experiment focuses on preferences for hypothetical health facility or home birth for future delivery. In the Scratchers experiment, respondents were asked to choose their preferred services from a set of hypothetical alternatives over several choice tasks. For example, the text box highlighted here presents a choice between 2 facilities. In Hospital A, there is a qualified birth attendant available to assist with delivery, but there is a possibility of being hit, slapped, shouted at, or insulted. In Hospital B, qualified birth attendant is not available to assist with delivery, but birth attendant will not hit or slap a woman and will not shout or insult a woman. Or home delivery. Studying how respondents choose across such scenarios allow researchers to quantitatively elicit the key drivers of decision making. Now, I would like to highlight some results from the exit interviews conducted in August 2017. Cases of mistreatment relating to health system conditions and constraints were reported in up to half of all deliveries. In as many as 1 in 4 deliveries, respondents reported staffing shortages and the poor physical condition of health facilities. The qualitative data supported the high prevalence of mistreatment related to health system condition and constraints reported in the exit interviews. For example, a 30-year-old woman in the in-depth interview said, "We were alert that day, and this one will deliver, that one will deliver. There is no privacy. We were looking at each other just like how baby worms are delivered." Instances of mistreatment relating to poor rapport between women and healthcare workers were the second most prevalent dimension, with 46% of women reporting such experiences. Women in the in-depth interviews and focus group discussions corroborated those findings and went on to describe how poor rapport with birth attendant manifest. For example, a 30-year-old woman in the in-depth interview said, she, the health worker, checked and said the baby was not due yet. She was rude and went out and continued talking with her friends. About 44% of the women reported experience incidences of mistreatment relating to failure to meet professional standard of care, most commonly reported being lack of informed consent processes by 25% of women. In the in-depth interviews and focus group discussion, women described profound displeasure at being neglected even though they were in a facility. Women highlighted experiencing episiotomy without pain relief even when they expressed pain. For example, a 24-year-old mother in-depth interview said, "I had a tear during delivery. The health worker just started episiotomy without any injection for pain relief, while she knew that I was in pain." From the exit surveys, just 3% of women reported being beaten, pushed, slapped, or poked during delivery, and about 11% of women reported experiencing some form of verbal abuse. According to women in the in-depth interviews and focus group discussions, use of force was primarily manifested as women being slapped or hit during labor and delivery, while a common manifestation of verbal abuse recounted by women in the in-depth interviews and reinforced in focus group discussions included health workers being unfriendly, shouting, or scolding women. Now, I would like to highlight some results from the household survey conducted in August 2018. In the IDS Household Survey of August 2018, we asked women with facility-based childbirth in the preceding 12 months about their experience of facility-based childbirth. We also asked women that delivered at home in the preceding 12 months their expectation of mistreatment occurring during facility-based childbirth. Our findings indicate a high expectation of mistreatment occurring during institutional delivery among women in the community that delivered at home, as highlighted here in the green bars. Next, I would like to highlight some results from the Discretus experiment conducted in March 2018. The positive sign of the estimated coefficient that is above 0 indicates that the attribute level has a positive effect on preferences for facility-based childbirth. Conversely, a negative coefficient that is below 0 indicates a negative effect on preferences. The most important attribute level that influenced the likelihood of a woman choosing a facility-based childbirth was good health system condition, including having qualified birth attendant present during childbirth, drug and supplies available, clean and conducive birth environment, followed by absence of sexual abuse, and then physical and verbal abuse, meaning women are more likely to deliver or choose to deliver in a health facility where the health system conditions are good. For rural women in Gombe, poor facility culture, including unclean birth environment with no privacy and unclear user fee, had the most negative impact on preferences for facility-based birth, meaning a woman is less likely to choose to deliver in a health facility with poor facility culture. Summary of result and implications of findings. Mistreatment during facility-based childbirth in Gombe State is highly prevalent and predominantly relates to mistreatment arising from both health system constraints as well as health worker behavior. There is a high perception or expectation of mistreatment in the communities, even among those that delivered at home. Consensus among focus group discussion participants was that this constraint inclined some women to opt for home delivery or go to a private clinic if they had the money. Those findings shows that negative experiences of care during facility-based childbirth is limiting effort to increase coverage of institutional delivery in Gombe State. The likelihood of poor facility birth experience had a significant impact on stated preferences for place of delivery among rural women in Gombe State. At this point in time, enhancing delivery environment in Gombe would have the most positive impact on women preferences for a facility-based childbirth. At the end, we would like to thank the Gombe State Primary Healthcare Development Agency, the implementing partners, our funders, and our measurement learning and evaluation partners, Data Research and Mapping Consult. We would like to thank the people of Gombe State for their contribution to this work. Thank you very much.